All right. Welcome, everyone, to another episode of the Vitality Code podcast. Nick, I know you didn't know this, but Jason is not here again. He, for those of you who don't know, he has a young daughter. And so he had some family stuff come up. I said, Jason, I got it. I got you. I'm your little brother, but I'm going to take the thing today. So we're going to do another solo episode, my man.
Yeah, all right, let's do it. I'm excited.
You got a young one too, so you know how that stuff goes.
I totally get it. Yeah.
You got to do what you got to do.
Yeah, 100%. It's you changes everything. I will tell you, that's my first, and it's like how old is your oldest? Like, when were you in my shoes? I'm in the 18 months range. I'm
in the 18 years age.
Oh, see, so it's
Yep. My oldest is 18, my middle is soon to be 12, and my youngest is 6.
Okay, yeah, all right. So you've been doing this.
You're
for a
in the
couple
thick of it,
now.
Man. Yeah, oh God. I know. I was on a trampoline last night, and I was like, I've been on this dang trampoline for like 15 years, man. You would think I'd be better, but I think I'm just glad I haven't injured myself.
No doubt. It's but yeah, man. I totally get it. It is wild. It's the best thing ever. But yeah, it's interesting to be like in this phase of it. You know what I'm saying?
Yes.
It's like so many things people told me. I'm like, they were spot on. You know, so many things people told me, you can't really describe it. I now can't describe it. You know, it's just it's so much of that. It's the best.
It is. It's awesome, and it's such a weird thing to happen in life. There is definitely life before kids and life after, and you can't grasp. I don't even remember what life before kids is, and before I had kids, I could not have imagined what this would actually be like. It is definitely a life altering.
It is, no doubt. It's I feel like, I can't even remember what it was like before, and that was, like 2 years ago.
It wasn't long ago. You will lose that ability. The other thing is too, like I used to Jason and Jeff, 2 brothers, but like the names, I get all my daughter's names. They're just like an amalgam of each other, and I forget.
Right.
You look at pictures and you're like, oh God, who was that? That looks like, I'm not sure. It's weird. It's just kind of like time becomes this weird concept that
no doubt
after a decade you lose for sure.
No doubt.
But yeah, Jason's in the thick of it with you too. So I'm glad to be out of those stages. No more diapers, no more baby stuff. But this is the last girl for us. So every time whatever quote unquote phase passes, I'm like, oh, this is the last time I'll do this.
Right.
Grandkids. Yeah.
Yeah, that's right. Yeah, no doubt.
So, but I thought, Nick, what we do today is I'm going to just I'll talk to the proverbial you. I'm going to talk to a male patient, kind of like we did with the female when we went through that quick synopsis of the menopause, premenopause state. Let's talk about testosterone and actually just like what a quick little mini explanation of their labs might look like, which is kind of what I do in my initial exam. Because every guy wants to know, like, how's my number? Is it good? Is it bad? Like, I'm having X, Y, and Z symptoms, but are my numbers good? Do I have low testosterone? And that's not like a cut and dry black and white thing. So I kind of go through a similar talk. As you can tell, I learned visually, so I draw out a lot of stuff. I have a big blackboard in my office. And so the things that I drew last week are the actual things that I draw when I'm going through a patient. It looks like what was that, Goodwill Hunting or something, where I'm just kind of, it's all scribble, but, and I do the same thing with my males. I'll draw out levels and numbers and labs and all that kind of stuff. So we'll kind of go through that. I went on the little whiteboard app and I put those out there. So we'll bring those up on the screen. But what a lot of guys want to know, their first question is, are my numbers good? That's their first thing that they want to know. And I got a little convoluted there. Let's see if we can erase some of this. They want to know, is my numbers, and let's put these back in while we're talking. They want to know, are my numbers good? And so the first thing I say is like, well, that's not an easy cut and dry answer. If we look at research, which we will do, we'll start to form a picture of where you should have been. So that's at the top right there, the little arc, and it says the 8 to 1200. So this is sort of your total testosterone. I didn't write that in there, so let's go ahead and put that in there. That's your total, big T, little t testosterone. That's your total testosterone. And that was likely your peak when you were 17, 18, 19, 20, 21, 16, 15. There's always that guy in like, sixth grade that had a beard. That was not me, by the way. But, and then there was a guy who didn't, was a late bloomer and maybe didn't peak till he was 23. But that hormonal peak, that peak of your testosterone was most likely 8 to 1200. And so what I drew on the side there, as you can see over here, there was outliers to every situation, right? So no doubt some guy only peaked at 600 probably, right? And there was no doubt some guy that peaked at 1400. We don't know what these were for most men because we don't draw labs when they're 18 or 19 or 17. So we're just using averages. And I always tell people, you aren't the average of 10,000 people in a study 10 years ago. You are you, but we have to start somewhere and we have to find some normative data. So what I generally will tell patients is, I don't know if you were 600. I don't know if you were 1400. Frankly, you don't know. Were you 8 to 1200? Most likely. And I say, well, what if we did this? What if we just said you were the average of all the averages? You were right down the middle. You were 1,000. And so we'll just say you weren't you weren't early bloomer, late bloomer. You were 20 years old. You were 1,000. You were just the average of all the averages. We would say then that testosterone should hold steady till you're 30, 35 years old. Then from there, you can expect to decrease. If you are a man living on Earth, you are going to decrease in your testosterone in a linear fashion, 1 to 2% yearly, depending on what research you read. And so we could start to draw some idea of the proverbial you, although it won't be correct because we don't know what your levels were, but we can start to lay a framework is what I tell my patients, right? So if your levels are this, you can see where it would fit in sort of a typical average number. A couple of things that we are seeing, I also draw on here, is one of the things that we're starting to see is that this 1 to 2% yearly line that is represented over here, we're starting to see that get a little steeper. And so instead of being 1 to 2%, we might be seeing a 3 to 5% drop. And so testosterones are getting lower quicker. Another thing that I'm also seeing is we get this 1 to 2% drop, and then we have a plummet, and then it starts again. And this, we don't often know what causes that plummet up there, but think of it as like maybe your first job. Maybe a health crisis happens. Maybe you get an ICU. Maybe you have a car accident, right? It could be some brain trauma. It could be something that's not simple, but as easily identifiable as that. But maybe it's just the point at which you had your kid who's now 18 months old and you're not sleeping really well for the past 18 months. Or in my case, you haven't slept well in 15 years. But, so maybe it's like it kind of, you get your first big job, you have your wife, you have your kid, life changes, and you aren't in college working out all the time, sleeping. Even if you're partying, you can still sleep when you want to, should you choose. When you have a child, that hopefully should change for you, and you might be pulling a lot of all-nighters. You could have a child that causes you to do all-nighters for 12 months, right? Not every baby is a sleeper right out of the gate. Not every baby is terrible at sleep, but you might be one of those. And so we are seeing these sort of big precipitous drops, then a leveling out. It's not a continuous drop, but it lowers your overall, and then you start to go down that 1% again. So this is kind of what research tells us. And so we would have somebody's lab number in front of us and we'd say, all right, sir, you're at X. Here's what research tells us. You might have been this guy on the left at 600. You might have been this guy on the right at 1400. You probably weren't. You're probably not an outlier by the nature of outliers. They're just less likely to come across. So let's just say, for sake of ease, that you were middle of the road, 1,000 was your peak. You held till you weren't 30 or 35, you were 32, and you dropped 1% a year. Here's where that theoretical version of you should be. But I tell them, frankly, it is a bit of an exercise in futility for you as an individual, right? Statistics don't apply to an individual. You're an N of one. And so statistically speaking, this could be way off base for you, but it lays the framework so you can start to understand where your number fits. The next thing I do is this little picture on the left over here down at the bottom, followed by these numbers right here. And so what I tell people next is this is not based solely on some research article, some white paper that's been in a peer-reviewed journal. This is a culmination of my practice, what I see with my patients, the research and the outcomes of doing testosterone supplementation for quite a few years now. And what I tell patients is this number on the far left, these bigger values right here, those are your total testosterone. This number in this column is going to be your likelihood of success with testosterone replacement should you choose to do it. So not to say whether this number is normal or abnormal, but rather to say if your number is X, if your total testosterone is X, this is kind of where you can expect you can place your expectations of recovery of your symptoms based on that number. So again, this is not your number is 700, you should or shouldn't do it. Your number is 300, you should or shouldn't do it. But if I were to choose to spend the time, the effort, the money, the management, the follow-up, the take on the risk, the pros, the cons, what, in your opinion, sir, the patient speaking to me, what is your opinion of my likelihood of success with this treatment? And then I say your likelihood of success is determined in part by these numbers, and success is defined by improved mood, libido, drive, energy, muscle, vitality. Speaking of kids, like we did earlier, like last night at 7 o'clock on the trampoline with two girls under 12, like it's not easy to do at 7 o'clock at night, and especially if your testosterone is low, you've worked all day, you're tired, you're fatigued, you're a little bit moody, you're cranky, you're falling asleep on the couch at 7 o'clock at night, and then waking up at 10 and trying to go back to sleep. For me, that's the real bang for your buck with testosterone. Sure, the gym is cool, but it's not, in my opinion, at all why guys do testosterone. It's a great it's a great side effect, so to speak. As I tell patients, it's good to have good progress in the gym. It's important for your life. Muscle mass is 100% a great thing for your health. Testosterone will not make you Mr. Olympia by any means. It just doesn't, it can't do that, right? It has so many androgenic effects. And one of those is improved mood and drive. And so what are your chances of success based on your number, sir? Well, if your number is here in the middle at 500 to 600, and it depends on their age, right? If I have a 30-year-old in front of me or a 40-year-old or a 50-year-old, these numbers will change a little bit. So I just sort of drew averages because we're not talking about a specific patient. But if your number is 500, 600, you're right in the middle. I don't know. It's hard to say exactly. It's like a 50-50 shot. You could have been this guy over here at 600 and you've held great. You could have been this guy here at 1400 and you've precipitously dropped. If this was a 65-year-old patient, not bad. If this is a 26-year-old patient, maybe not good. But still, even taking into account all of those, I still give these numbers like a 50-50 shot, meaning testosterone can only do what it can do. It doesn't mask symptomology, right? It doesn't, if you are depressed, speaking of depression from the earlier one, if you have frank clinical depression, testosterone is not a sole treatment standalone for clinical depression. Can it help with gray cloud? Can it help with depressive type symptoms? 100%. But if you are just clinically depressed, it can't do what it can't do. So your chances of success, I kind of put in the 50-50 marker, because not usually guys, I tell them, if you came in at 100 or 1200, I can tell you right off the bat, I don't even need to see you, just come in or don't come in, right? Those are easy numbers to delineate and decipher. But most guys fall in this sort of gray area. And so as that number goes up from that 500, 600 closer to the 700, 750, your chances of success get lower. Now, you might be an outlier. You might have been the 1400 guy and you might do great. And we might say, I've seen 5 other doctors. I'm having erectile dysfunction. I'm having mood disturbances. I'm tired and fatigued all the time. I have zero libido. I'm putting on fat. And I've tried X, Y, and Z, and I'm on a good regimen of working out and diet, and nothing's helping. We may decide to do it. But again, you're in a cohort that is not necessarily likely to do well based on that number alone, not taking into account those other things, which may change that percentage. And then as you travel down closer to the 350 mark, your chances of success dramatically go up. No 30-year-old should be at 300 in a normal, robust, ideal state. But again, we're seeing these percentages drop quicker. We're seeing high stress, high demand environments cause precipitous drops in testosterone. And so therefore, if you're 32 and your testosterone is 300, even though on this arbitrary LabCorp scale for your region, which changes for region, which is not normal or abnormal, it is an observational data, and that number has changed in my region. I saw someone's labs, they came in from the late 90s in the LabCorp range, which further proves this side of the graph. The LabCorp range was 350 to 1100. Now it is 264 to 964. So what they're finding in their normative data is getting lower and lower as an observation. So if your numbers are in the 300s, yeah, your chances of success are high. Now, there's more things that go into that. Are there specific pros and cons we need to talk about? Are there fertility issues that we need to discuss? Are there risk factors that we need to discuss? Are you in a disease state? Is there liver failure? Is there something, an outlier that would cause us some pause? Regardless of whether or not you would do well, it may not also mean that you should do it. So just like 750 doesn't mean you absolutely cannot do it. 350 doesn't absolutely mean you should do it. This is part of the decision-making process that you have to determine for yourself. What I find most people is they kind of fall between these ranges. You might come in at 400. It's not clear. It's easy to understand. It's not a clear-cut yes or no. So maybe your number is 400, but you feel great. No issues at all. Maybe we decided to hold off and not try it. Maybe you come in at 400 and you have significant symptomology and no risk factors, and for you, the pros strongly outweigh the cons, then yes, we may decide to do it. What are some of those other things that play a role? I hear this a lot as the eruption of the things like I'm doing, the podcast world, the science world, and I think they're great. So let's talk about your SHBG. What is that? Your SHBG, sex hormone binding globulin, is something that's going to influence the effect of your testosterone. A robust SHBG will give the feelings of a lower testosterone, so to speak. It makes less of your free testosterone free and available for the easy physiological use, right? Testosterone garners its effect intracellularly, and if it's connected to your SHBG, then it is less likely to be able to oops, I lost my screen there. Less likely to exert its physiological functions for you. And so we want to make sure that we take these things into account when they come into account, right? The other thing I like to talk to my guys about is their estrogen levels. And so we start to see this sometimes is the estrogen levels will change as the testosterone drops maybe somewhat and the estrogen rises somewhat. That can set up an environment that may be less likely to produce positive effects, even though maybe the frank testosterone levels aren't significantly low. We can start to see some disruptions. And we tend to see that, or I tend to see that in some of my older patients, which again leads us to the sort of started to talk about prostate issues and things like that. So this is the sort of talk that I give for guys, whether or not their number is normal. So it's not easy as just saying it can be. I've seen guys come in with testosterones in the hundreds, and they're under 40. Not good, not normal. The negatives of any negatives of testosterone therapy are strongly outweighed by the pros for that person. They're doing themselves, in my opinion, a disservice. Higher rates of lots of disease processes happen at that. It can be due to some known causes. I've had patients on other medical treatments that are known, whether or not they're told, they are commonly known to lower your testosterone. And maybe that was important for them at the moment, right? I can think of something like maybe methadone. That's a real strong outlier. I realize that, but it is known to tank your testosterone, right? But if you have an addiction, that may be what's saving your life. but we also might see some significant testosterone drops in that state. Things like chronic prednisone use actually lowers testosterone. So maybe you had RA, rheumatoid arthritis, and you were on a prednisone dose for a long period of time. Maybe you had a skin condition. You see this a lot. And you were having some dermatological issue and you were doing 10 milligrams of prednisone daily and you wake up and it's been years. Maybe there's some strong autoimmunity that you see that sometimes and it affects other things. And so we are seeing testosterones lower and lower across younger and younger age groups. But this is the kind of thing that I will sit down before we talk about individual symptomology. If this is the right decision for you, what are the management issues that you should think about, right? Testosterone is a fairly safe medication. But it is a little bit of a higher management. There takes a little bit more work on your part. You have to come in for regular blood work. We need to check your estrogen. We need to titrate any estrogen blockers. We need to find out if you are better with injections, if you're better with sub-Q injections, IM injections. What's your timing? Are you a pellet patient, right? There's a lot more management than if I were to write you just a blood pressure med and say, your blood pressure is a little up. Let's give you lisinopril. I'll see you in a year, right? It's not that easy. And so this starts that talk, though, of is my number normal or abnormal? Guys often want to know that. And then lastly, over here, I've sort of drawn this little arrow down there at the corner of the 85% is like, what number do I need to get to? That's another common one that I hear guys say. And if you're starting out at that 350 and you're likely to have symptoms, and if you were naturally occurring around 750 and you're not likely to have symptoms, then it makes sense to some degree that we're going to start pushing towards that number. And every sort of chunk up that same linear fashion from 350 to 500, 600, from 350 to 750, you're likely to incur symptom resolution. So most guys need to get to a physiological optimal state for resolution of symptoms. Now, this is not saying that someone can get symptom resolution at 600 or saying that maybe they have hemoglobin hematocrit changes that happen at a less than optimal testosterone number. And so we need to monitor their number and maybe keep it a little bit lower or something like that. Not taking into account those outlying situations, it makes sense then that we would follow a similar scale by raising your testosterone from those 300s up to those high 7s or 8s. That's typically where most guys start to get symptom resolution. And again, age plays a role, route of delivery plays a role, whether you're doing pellets, whether you're doing injections. How are you measuring those injections? Are they peaks or are they troughs? Are they averages? What is your estrogen response on those injectables? So those will all play a role. Where's your free testosterone at a level? If you have a high free, maybe you don't need as high of a total testosterone. If you have a really high SHBG, maybe we need to take you higher than normal. Maybe we get you to 1,000 or 1,100 or 1,200 to get the same effect that somebody else with a lower SHBG would have to get a similar effect. So again, this is what I always say at the end of this because there's a ton of information. Like that's testosterone replacement therapy in 20 minutes, guys. And, it's like drinking from a fire hose sometimes. But this starts to lay the groundwork. Even if they don't grasp it all in that moment, at least we've started to elucidate versus just saying, oh, you should take testosterone. You don't need testosterone. Again, that's one of my least favorite sayings. I can't stand when physicians say you don't need that. Who are you to determine what I do or don't need? Your job here is not to determine that for my life. Your job is to adhere to your license requirements. Your job is to give me the pros, the cons, the risks, rewards, and then let me make the decision that's best for me. I don't need or not need a statin. I don't need or not need surgery. Now, we're not talking about life-threatening situations, but, maybe I have a torn meniscus. I don't need surgery. I may choose to avail myself of that, which I have because it hurts so damn much. And I was really thankful that I had a really great orthopedic surgeon over here that did my knee. But, and I don't like that need word. I hear a lot of primary care say, you don't need testosterone. And I don't know exactly what that means. It sounds very paternalistic to me, and maybe that's coming from my own personal perspectives where I don't like people telling me what to do. But let me rather make those decisions for myself, and let's sit down and let's avail ourselves to the information. Spend 10 to 15 minutes with me explaining where I fall in this normative data, explain to me how my symptoms are related to the testosterone replacement. Sit down, explain to me the risks and the rewards, and maybe it is something that I shouldn't do. Maybe the risk is too high, or maybe it's not, and maybe that's a decision we can make together. So I hope that information kind of helps lay it out. I know it was quick, and I know there's a lot in there. So again, similar to the last one, we're going to go in there and put some show notes in there and hopefully lay out some of this data. Maybe I can recreate that little drawing there a little more clearly, and then we can put that in the show notes for you guys to reference later. But again, hopefully my illustrious, well-educated brother will be back on the next podcast, Nick, and we can dive into some topics. I know we were discussing off camera some Ozempic and semaglutide topics, and there's also some new ones coming out. Believe it or not, there's a third generation. Yeah, so the semaglutide first generation, Ozempic, tirzepatide, the second generation. There's a third generation that's coming out, GLP. So GLP-1, GIP, and now there's a GLP-2, I believe, that is coming down the pipes. Yeah, so weight loss is going to be here for a while.
Yeah, absolutely.
There's also some articles. I know you were talking about the Ozempic babies. Is that right? With the you saw?
Yeah, it had come up maybe very recently that there were some women that were experiencing either like fertility issues or were flat out on birth control, getting pregnant and saying that like the only real change was that they started taking, one of these drugs, Ozempic, or one of the, that family. And so, yeah, very, very interesting. Those drugs seem to be, I saw somebody on Twitter said, geez, these things people are, starting to talk about them for helping people with addiction, like alcoholism, weight loss. Now they're helping get people pregnant.
I know, right? I tell you, I know this amongst many physicians who are prescribing some of these drugs, that the curbing of cravings for food was closely related to the curbing of symptoms for alcohol. I don't know about drugs, more illicit drugs, but alcohol, which I guess is a drug, but alcohol consumption, I would say for a majority of my patients goes down while they're on these, for sure. That is a 100% observable data point amongst. I don't know if the research is showing that yet, but it is 100% observable in patients and in practice. It's interesting.
Yeah, it is. It is. They seem to be, forever they've. My wife is a dietitian. She's specializes in like diabetes education. And those drugs have been phenomenal for people with diabetes forever. Like she talks about, like, these have been around forever. There was always speculation that people were taking them for weight loss, and like Hollywood and things like that. She used to talk about. That was always kind of the the conversation behind the scenes.
There's no more speculation anymore. There's no more speculation.
It's very obvious. Yeah, that was what it was. But yeah, they are. It is like every day something new comes out about these drugs.
It's very interesting, and we're starting learning this stuff as we go, and it'll be interesting to see what the next 20, 30 years plays out. I'm not sure exactly, but it'll be interesting to see. So those are topics that me and Jason can bat around. He loves to dive into the research and look at some of that stuff, so maybe we'll come back with some of those weight loss topics again. But maybe we should ask him to talk about, he can critique me. He's my older brother, so I'm like, hey, what do you think about this? I say this, what do you give me the stamp of approval? Even though we're both trained healthcare providers, there is still that dynamic where he's my older brother and, was a practicing physician before I was. And so I'll be interested. Maybe he can critique my initial exam there, my little talk that I give to my patients, and see what he thinks about that.
Yeah, no doubt. He can do the game film review.
Yeah, exactly. He can be the armchair quarterback.
Right.
He'll like that.
No doubt.
All right, Nick, great. I appreciate your time, brother. We will meet back in a week or so, and we'll hopefully have Jason back on here, and we'll get rolling again.
Yeah, absolutely. All
right, brother. Have a great one.
Awesome. You too. Thanks.
See you, man.